Let's talk about one of the most common labels you'll see in a patient's chart, the beta-lactam allergy. It's just a little note, right? But it can completely change how we care for a patient. And honestly, a lot of the time, it's for the worse. So what if I told you most of these labels are just wrong? Over the next few minutes, we're going to walk through the evidence that lets us safely question these labels and get back to choosing the right antibiotic for the right reason. Okay, so here's how we're going to break this down. First, we'll get a handle on just how big this problem is. Then we'll dive into the science, this huge shift in how we think about cross-reactivity. After that, it gets practical, a guide to risk stratification, followed by a few clinical cases to test our skills. And finally, we'll tie it all together so you can start prescribing smarter and safer.
So let's just frame the issue. Why do we even care so much about this one little line in a medical record? Well, because the ripple effects of a penicillin allergy label are massive. They affect the patient right in front of you, and they contribute to the global fight against antimicrobial resistance.
I mean, just think about the numbers. Walk onto pretty much any hospital floor, and you'll find that up to 15% of your patients are carrying this label. It's something we have to deal with every single day. But how real is it? And here's the paradox, the real kicker. When you actually do formal allergy testing, it turns out that more than 90% of those patients are not allergic at all. They could have been getting penicillin safely this whole time. Most of these so-called allergies are things like a forgotten childhood rash, or maybe a side effect like diarrhea, things that have been blown up into a life-threatening label. You know, it seems penicillin allergy is the most common inherited condition that isn't actually genetic.
And look, this isn't just some harmless error on the chart. When we avoid first-line beta-lactams, it forces us down a path of using broader-spectrum drugs. And that kicks off this whole cascade of badness, all backed by data. We see higher rates of adverse drug events, a bigger risk for nasty infections like C. diff, and frankly, worse outcomes for patients with everything from bacteremia to surgical site infections. And on top of all that, it's a huge driver of antimicrobial resistance.
Okay, so now we get to the really cool part. The core science that actually lets us dismantle this problem. For years, we were stuck on this flawed idea about beta-lactam structure, but the thinking has completely shifted, and it really all boils down to the side chains.
The old dogma was simple but wrong. If it's got a beta-lactam ring and a patient is allergic to one, then they're allergic to all of them. We now know that's just not true. The real target for the immune system isn't the ring in the middle, it's the R1 side chain that hangs off of it. So if those side chains are different, the risk of a true cross-reaction is incredibly low, even if your patient had legitimate anaphylaxis to another beta-lactam. It's kind of like they're from the same family, but one's an accountant and the other is a rodeo clown. They're just not going to wear the same clothes.
So that's the science. How do we actually use this on the wards? Well, it all starts with taking a really good history. Our goal is to take that vague penicillin allergy note and turn it into something we can actually act on.
You've got to be a bit of a detective here. There are 4 key things you need to find out. First, timing. Did it happen right away, suggesting a classic IgE-mediated reaction, or was it delayed? Second, what did it actually look like? Hives and swelling are high risk. A simple flat rash, not so much. Third, how severe was it? Was there intense itching, swelling, any hint of cardiovascular trouble? And finally, when did this happen? We know that a lot of these Ig-mediated allergies fade over time, and many people lose their sensitivity after 5 or 10 years.
And once you have that information, you can start putting patients into different buckets. At one end, you have your low-risk histories, maybe a non-itchy rash that showed up hours later, years ago. At the other end, you have high-risk immediate reactions like anaphylaxis. And it's absolutely critical to also screen for those rare but severe delayed reactions like SJS or DRESS, because those are a hard stop for all beta-lactams. This table really guides your next move. For low risk, you can often just proceed carefully. For high-risk IgE reactions, you just need to avoid drugs with similar side chains.
All right, theory is one thing, but let's put this into practice. We're going to run through 3 quick cases to see how these principles really work in the wild.
Okay, first up, this is a super common one. A vague, old reaction that doesn't sound very severe. Now the patient has a life-threatening infection and the best drug for it is a cephalosporin. What do?
You proceed with the ceftriaxone. That's the right call. The history is low risk across the board. The chance of a true allergy here is already tiny. But even if it were real, the risk of cross-reactivity between amoxicillin and ceftriaxone is basically zero because their side chains are so different. Withholding a life-saving drug in this scenario would be the wrong move.
All right, let's up the ante a bit. This isn't some vague history. This is a documented, real-deal, severe allergy to penicillin. But cefazolin is the absolute best drug for surgical prophylaxis. So, can you use it?
And the answer, which might feel a little scary at first, is yes, you can. This is that paradigm shift in action. The severe reaction was to the penicillin side chain. Cefazolin side chain looks completely different. We have tons of evidence from allergy challenges and clinical use showing that these patients can get cefazolin safely. This is a massive win for antimicrobial stewardship in the OR.
Last one. A patient has a known, confirmed allergy to a specific cephalosporin, ceftazidime. You need to treat a nasty gram-negative bug, and aztreonam is on your list of options. Can you use it? And, if you're still not sure, well, that's what the infectious diseases consult is for. We also need to justify our salaries.
This is the one where you slam on the brakes. You have to avoid it. This is the exception that proves the rule we've been talking about. Aztreonam, even though it's a monobactam, has an R1 side chain that is practically identical to the one on ceftazidime. That structural similarity means there's a real significant risk of a cross-reaction.
So let's pull all these threads together. By getting past that outdated dogma and using a systematic, evidence-based approach, we can start prescribing in a way that's so much smarter and so much safer. Think of this table as your clinical cheat sheet. If your patient is allergic to amoxicillin, you steer clear of cephalosporins with similar side chains, like cefprozil. But agents like ceftriaxone or cefazolin, they're totally fine to use. This kind of rational, side chain-based selection is really the core of modern beta-lactam stewardship.
And the payoff for doing this? It's huge. We can finally, safely, delabel patients and free them from a lifetime of getting second-best therapy. We get to use our most effective, narrowest spectrum antibiotics. And that means fewer side effects, a real weapon against antimicrobial resistance, and better outcomes for our patients. It is a win, a win, a win.
So I'll leave you with this final thought. For far too long, we've treated that penicillin allergy label like it's a sacred text, a fact to be obeyed without question. But the evidence now forces us to see it for what it is, a clinical problem that needs to be investigated and in most cases solved. Because when we solve it, we're not just doing better by one patient. We're protecting our most precious class of antibiotics for everyone.